Welcome back to the Deep Dive. Today we're doing something a little different. We are stripping away the usual format.
We are.
I want you to imagine you're in the hot seat. The Gujarat University MD Anesthesiology final exam is. It's just around the corner. The clock's ticking.
And you've got this mountain of books in front of you. Guyton, Miller, Morgan, Teresia. It's completely overwhelming.
It is. So that's our mission today.
Exactly. This isn't just a discussion. Think of it as a high-intensity coaching session. We're going to take all that source material, that whole stack of books, and we're going to distill it
Into what?
into the perfect 20-mark answer for a topic that examiners just, well, they love to use it to separate the good candidates from the great ones, the parathyroid glands.
The goal here is simple, to get you ready for that viva voce. When the external examiner leans in and starts grilling you on neck anatomy and physiology, we're going to cover embryology, anatomy, physiology, the disorders, and, of course, the big one, comprehensive anesthetic management.
And, there's a reason it's a classic Viva trap.
Why is that?
It's because the glands themselves are tiny, but the physiology is just massive. It connects everything, basic anatomy to life-threatening electrolyte crises in the ICU.
So if you can handle the parathyroid...
If you can handle the parathyroid, you're telling the examiner you can handle complex airways, you understand cardiac pharmacology, and you get renal physiology, all in one question.
Okay, let's start at the very beginning. The why. I mean, they're physically tiny, just 4 little split peas sitting in the neck. Why should an anesthetist be so obsessed with them?
Because calcium.
Yeah.
Calcium controls the entire game, as we've seen in the text, right? Calcium stabilizes nerve membranes.
Right.
It's absolutely fundamental for cardiac contractility.
Yeah.
It's needed for blood to clot. In the ICU, in the OT, calcium disorders are incredibly common. And if you miss them,
The consequences are severe.
the patient dies. It's that simple. So you need to frame your answer from the get-go. Sir, this isn't just about a gland. It's about maintaining the body's entire electrical stability.
Okay, I like that framing. Let's build this perfect answer from the ground up then. We've got a huge 22-point roadmap to get through. So we have to start where I think a lot of people get confused. Embryology. High yield for the
It's
Viva.
so counterintuitive. I remember this from medical school.
It is. And that's because it's a paradox. This is the first place students start losing marks. We know the parathyroids come from the endodermal pharyngeal pouches.
The third and fourth pouch.
Exactly. The third pouch and the fourth pouch. Now, logic would suggest that the third, being the lower number, would stay high up in the neck.
And the fourth would go lower.
Right. But biology just doesn't care about our logic.
Yeah, no, it doesn't.
The inferior parathyroid glands, they actually originate from the third pharyngeal pouch.
Okay, wait. So the inferior comes from the third.
And the superior glands come from the fourth pouch. They literally swap positions during development.
So why? Why does the third pouch travel so far down?
It has a travel buddy.
The third pouch also gives rise to the thymus. And the thymus has this long migration path, right? It has to go all the way from the neck down into the anterior mediastinum.
And the inferior parathyroid is just along for the ride.
It's embryologically hitched to the thymus. It gets dragged down with it.
It's like you're on a train talking to a friend, and you completely miss your stop and end up in the next city over.
That's a perfect analogy. And look, this isn't just trivia for a quiz night. This has direct anesthetic relevance.
How so?
Because the inferior glands travel so much further, their final resting place is highly variable. They're ectopic in a pretty significant percentage of patients.
So they might not even be in the neck.
They could be inside the thyroid gland, they could be in the carotid sheath, or they could be all the way down in the mediastinum with their old friend, the thymus.
Which completely changes the surgical plan.
Completely. If the surgeon is digging around and can't find the adenoma in the neck, suddenly we're not talking about a simple collar incision anymore.
We could be looking at a sternotomy.
Yeah.
Or the thoracoscopy.
Exactly. A much bigger deal. So if you can say to the examiner, sir, the embryological migration dictates the potential for a variable surgical approach, including mediastinal exploration, you've just put yourself in the top 10%.
Okay, got it. Third goes low, fourth stays high. Let's move on to visualizing the anatomy. This section is marked very high yield. So typically 4 glands, what do they actually look like?
P.D. Teresia describes them as lentiform, lens-shaped.
Okay.
And they're this sort of yellow-brown color. The problem is They look dangerously similar to lobules of fat.
Oh, is that not good?
No. This is precisely why accidental removal during a total thyroidectomy is so common. The surgeon literally can't distinguish them from the surrounding adipose tissue without a very, very keen eye.
And where exactly are they relative to the thyroid?
Generally, they're on the posterior surface of the lateral lobes of the thyroid gland. The superior glands are a bit more constant in their position, usually around the middle of that posterior border.
The inferior ones.
They're the wild cards, like we said. They're usually near the lower pole, but honestly, they can be anywhere.
Let's talk about the blood supply. This is critical for both the surgeon and for us.
It is. The primary blood supply for both the superior and inferior glands is the inferior thyroid artery.
Wait, even for the superior glands, that seems risky, having one main vessel supplying everything.
Well, there are some anastomoses with the superior thyroid artery, but yes, the inferior thyroid artery is the lifeline. And this is crucial. This explains post-operative hypoparathyroidism.
How so?
Because even if the surgeon doesn't physically cut the glands out, if they ligate the main trunk of the inferior thyroid artery too far laterally, they can devascularize all 4 glands at once.
So you leave the glands in place, but they're dead. They're ischemic.
Precisely, which means the anesthetist has to be watching for signs of hypocalcemia, even if the surgeon says the glands were technically saved.
Wow. Okay. Now, there's a specific anatomical relationship here that Morgan and McKeel call the surgeon's nightmare, the recurrent laryngeal nerve.
Ah, yes. This is the gold standard for a surgical anatomy question. You have to be able to visualize this in your head. The nerve is running up in the tracheoesophageal groove.
Right.
And the relationship is very specific. The superior parathyroid glands are usually dorsal or behind the recurrent laryngeal nerve.
Superior is dorsal.
And the inferior parathyroid glands are usually ventral or in front of the nerve.
Okay, superior dorsal, inferior ventral. Why does this exact orientation matter so much to us?
It matters for nerve monitoring. We often use nerve integrity monitoring in these cases.
Right.
If you know this anatomical relationship, you can anticipate when the surgeon is working in the danger zone. When they're dissecting a superior gland, they are working behind the nerve. When they're dissecting an inferior one, they're working in front of it.
It shows you're thinking about the surgical field.
It shows you understand the 3-dimensional space, not just the drug chart. That's extra marks every time.
Okay, anatomy is down. Let's pivot to the engine room. Physiology. The parathyroid hormone itself, PTH.
PTH is an 84 amino acid polypeptide. It's secreted by the chief cells. I always like that name.
The cheese is in charge.
The chief is in charge of calcium.
Exactly. And the chief has a thermostat, right?
The calcium sensing receptor, or KSR, it's a G protein coupled receptor on the cell surface, and it operates on a very elegant negative feedback loop.
But it's a bit unusual.
It is. Unlike most hormones that get stimulated by a positive signal, PTH is stimulated by a lack of a signal. Low ionized calcium in the blood takes the brake off, and PTH is released. High ionized calcium puts the brake back on, and secretion stops.
And there's a crucial cofactor here that often gets forgotten in exams: magnesium.
Absolutely essential. You have to mention magnesium. It's required for the adenyl cyclase mechanism that releases PTH, and it's also required for the peripheral action of PTH on the target organs.
So what happens if you don't have enough magnesium?
If you have a patient with severe hypomagnesemia, think about an alcoholic patient or someone who is severely malnourished, they can present with a functional hypoparathyroidism.
Functional. So their glands are actually fine, they just won't work.
Correct. The glands are there, they're healthy, but they can't release the hormone. You can pump that patient full of calcium, but until you correct the underlying magnesium deficiency, their calcium levels will never stabilize.
That's a classic Viva scenario, isn't it? Unresponsive hypocalcemia.
Textbook.
Okay, so once PTH is released, it goes after the big 3 targets: bone, kidney, and intestine. Let's break down the mechanism for each, starting with bone.
In the bone, PTH has what you'd call a biphasic action. There's a rapid phase and a slow phase. The rapid phase happens within minutes. It activates something called the osteocytic membrane pump to move calcium from the bone fluid, this sort of labile pool, into the blood.
And the slow phase.
The slow phase takes days. It actually recruits osteoclasts, the bone-chewing cells, to physically break down the bone matrix to release calcium and phosphate. This is what causes the painful bones and the fractures in chronic hyperparathyroidism.
Got it. Now what about the kidney?
2 very distinct actions in the kidney. First, in the distal tubule, it powerfully increases calcium reabsorption. It's telling the kidney, do not pee out the calcium, we need it.
And the second action.
This is the key to the biochemistry. In the proximal tubule, it inhibits phosphate reabsorption. It actively tells the kidney to dump phosphate into the urine. This is its phosphaturic effect.
So serum calcium goes up and serum phosphate goes down.
The calcium phosphate seesaw. That is the biochemical hallmark of PTH action. If you ever see a high calcium and a high phosphate together, you should be thinking of something else, not PTH. Maybe bone destruction from malignancy or vitamin D toxicity. PTH splits them apart.
Okay, and the third target, the intestine.
This one is indirect. It's clever. PTH doesn't actually touch the gut directly.
Oh.
Instead, it stimulates a critical enzyme in the kidney called 1-alpha-hydroxylase. This enzyme takes inactive vitamin D and converts it into its active form, 1025-dihydroxycholecalciferol, or calcitriol.
And it's the calcitriol that works on the gut.
Exactly. The calcitriol then goes to the intestines and massively increases the absorption of calcium from your diet. It's a coordinated multi-organ attack, all designed to raise serum calcium.
Now for us, for the anesthetist, the big so what question always comes back to membrane stability, doesn't it?
Always. Think of calcium as a gatekeeper for the voltage-gated sodium channels on nerve and muscle membranes.
Okay.
It sits there and it stabilizes the channel. So if you have hypercalcemia, you have too many gatekeepers. The sodium channels are partially blocked.
So it's harder for the nerve to fire.
Exactly. The threshold for depolarization goes up. The entire nervous system becomes, well, sleepy. The patient is lethargic, weak, confused, constipated. Everything is depressed.
And in hypocalcemia?
The gatekeepers are gone. The sodium channels are wide open and leaky. Sodium rushes in easily. The nerves become hyperexcitable. They fire spontaneously with minimal stimulation.
And that's where you get the twitching.
The twitching, the paresthesias, the tetany, and the life-threatening laryngospasm.
So it's a simple rule, really. High calcium equals sleepy nerves. Low calcium equals twitchy nerves.
If you just keep that simple framework in your mind, you can derive almost all the clinical signs and symptoms.
Excellent. Let's apply that framework to pathology. Hyperparathyroidism. For the exam, we need to classify this. Primary, secondary, and tertiary.
Right. Primary is a problem inside the gland itself. Most commonly, about 85% of the time, it's a single benign adenoma.
And it's just pumping out PTH on its own.
It's autonomous. It completely ignores the negative feedback loop. So the result is high PTH, which causes high calcium.
Okay, what about secondary?
Secondary is a problem outside the gland. It's a physiological compensatory response. The classic patient is someone with chronic renal failure.
Why them specifically?
Because their failing kidneys can't activate vitamin D, so they can't absorb calcium from the gut. And they can't excrete phosphate, so phosphate levels rise and drag calcium down. This chronic low calcium is constantly screaming at the parathyroid glands to work harder.
So the glands are just doing what they're supposed to do.
Exactly. They become hyperplastic. All four of them get bigger as they try to compensate. So in secondary, you have a very high PTH, but the calcium is usually low or maybe normal. That's the key differentiator.
And tertiary is when the secondary goes rogue.
Perfect way to put it. After years and years of chronic overstimulation, like in a patient on dialysis for a decade, the hyperplastic glands develop autonomous nodules within them. They go rogue. Even if you fix the underlying problem, say with a kidney transplant, the glands don't shut off, they just keep pumping.
Right. Now, the systemic effects. We all learned the classic medical school rhyme. Painful bones, renal stones, abdominal groans, and psychic moans. We need to unpack that for the 20-mark answer.
Let's do it. So, painful bones. We talked about the osteoclast. You get osteoporosis, pathological fractures, and this classic condition called osteitis fibrosa cystica. You might see brown tumors on an x-ray.
Which aren't actually tumors.
No, they're not cancer. They're just pockets of hemorrhage and fibrous tissue from all the bone destruction.
Okay. Renal stones. Calcium oxalate stones. That's pretty straightforward. But what about the dehydration component?
This is the most critical point for the anesthetist. These patients have polyuria. They pee a lot. The reason is that high calcium causes a nephrogenic diabetes insipidus.
How?
It downregulates the aquaporin 2 channels in the renal collecting ducts. The kidney literally loses its ability to concentrate urine.
So these patients come to the operating room chronically and sometimes severely dehydrated.
Severely, which leads us to the abdominal groans. Hypercalcemia stimulates gastrin secretion, leading to peptic ulcers, and it also prematurely activates trypsinogen within the pancreas, leading to pancreatitis. They are also profoundly constipated.
And finally, psychic moans.
That's the sleepy nerve concept again. Confusion, depression, lethargy, poor concentration, and in very severe cases, coma.
We can't forget the heart. What are the cardiovascular effects?
Hypertension is very common through a number of mechanisms, but the specific ECG finding you must mention is a shortened QT interval. The repolarization phase, phase 3 of the action potential, is accelerated.
So let's put it all together. We have a patient for parathyroidectomy. They have fragile bones, they're dehydrated, they're hypertensive, and they have a short QT interval. How do we approach their anesthesia?
The preoperative assessment is all about volume, volume, and volume.
Okay.
You cannot safely induce anesthesia in a hypovolemic patient who also has potential myocardial depression from hypercalcemia. Their blood pressure will crash on induction.
So rehydration is step one, priority one.
Absolutely. Isotonic saline, 0.9% ACL. You need to restore that intravascular volume before you even think about going to the OR. We're often talking about correcting a deficit of several liters.
Are there any specific drug interactions we need to worry about?
Yes. If they are on digoxin, you need to be terrified.
Why?
Hypercalcemia massively potentiates digitalis toxicity. They act synergistically on the sodium-potassium pump. You can trigger fatal arrhythmias.
What about muscle relaxants?
Well, because of the sleepy nerves and pre-existing muscle weakness, they may be very sensitive to non-depolarizing blockers. You need to titrate them very carefully, and you must use a nerve stimulator. Don't just give a standard dose.
Okay, let's talk about the absolute worst-case scenario, hypercalcemic crisis. The patient comes into the ICU, they're obtunded, their total calcium is 15 or 16 milli-GDL. What's the protocol?
This is a true medical emergency. And step one, as we said, is aggressive hydration. We are talking 200 to 300 milliliters per hour of normal saline. You have to dilute the calcium and increase the glomerular filtration rate to promote excretion.
Do we give them Lasix? Furosemide.
This is a classic trap. You give loop diuretics only after the patient is fully rehydrated.
Why is that?
If you give Lasix to a dry patient, you just worsen the dehydration, which worsens the hypercalcemia. It's a vicious cycle. But once they are volume replete, yes, Lasix helps by blocking calcium reabsorption in the thick ascending loop of Henle.
What about medical therapy to actually stop the bone breakdown?
The gold standard now are the bisphosphonates pamidronate or zoledronate. They are potent inhibitors of osteoclasts. The only downside is they take 24 to 48 hours to really kick in.
Is there anything for more immediate control?
We used to use calcitonin. It works fast, within hours, but its effect is weak, and tachyphylaxis loss of effect develops very quickly. In certain causes, like malignancy or sarcoidosis, glucocorticoids are the answer because they block vitamin D-mediated calcium absorption.
Okay, that feels like a very comprehensive look at the hyper side. Let's flip the coin. Hypoparathyroidism.
The most common cause, by far, is iatrogenic. We did it. It's post-thyroidectomy.
Right.
Either the glands were accidentally removed or, more commonly, their blood supply was damaged.
But for a complete answer, we should probably mention some medical causes.
Of course. You have congenital absence, like in DeGeorge syndrome. You can have autoimmune destruction of the glands, and, as we mentioned, severe magnesium deficiency.
And there's that conceptual one.
Pseudo-hypoparathyroidism, yes. That's a fascinating one, where the tissues are resistant to PTH, the glands are pumping out tons of hormone, but the body just isn't listening.
The pathophysiology here is the excitable state.
Exactly. The gatekeepers are gone. Low calcium lowers the firing threshold. The sodium channels become unstable. The very first symptom is usually paresthesias, that tingling sensation around the mouth, circummoral, and in the fingertips. Then it progresses to muscle cramps.
What's the killer complication we have to watch for?
Laryngospasm. The intrinsic laryngeal muscles go into a full tetanic spasm. This can happen in the recovery room, and it is a complete life-threatening airway obstruction.
What about the heart?
It's the exact opposite of hypercalcemia. You see a prolonged QT interval. The heart takes too long to repolarize, which puts the patient at risk for torsades de pointe.
And contractility?
Decreased myocardial contractility. The heart muscle needs calcium for excitation-contraction coupling. A hypocalcemic heart is a weak heart, and it often doesn't respond well to standard inotropes.
For the exam, we absolutely have to nail the clinical signs. The eponyms.
Shostak's sign and Trousseau's sign.
Yeah.
You must be able to describe them accurately.
Shostak's is the face tap.
Yes. You tap on the facial nerve, just anterior to the tragus of the ear. A positive response is a twitching of the ipsilateral facial muscles, usually the upper lip. But you have to remember, about 10% of normal people have a positive Schwastik's sign. It's sensitive, but it's not very specific.
Trousseau's is the better test.
Trousseau's sign is much more specific. You inflate a blood pressure cuff on the patient's arm to above their systolic pressure, and you hold it there for 3 minutes. This induces ischemia, which makes the peripheral nerves even more irritable.
And what do you see?
You see a carpal spasm. The wrist flexes, the metacarpophalangeal joints flex, the interphalangeal joints extend, and the thumb adducts across the palm. It's called the obstetrician's hand. If you see that, the patient has significant latent tetany.
Okay, a patient is in acute tetany. How do we treat it?
IV calcium. Immediately. The standard dose is 10 to 20 milliliters of 10% calcium gluconate given slowly over about 10 minutes.
Why do we prefer calcium gluconate over calcium chloride?
Calcium chloride contains about 3 times more elemental calcium per ampule than gluconate. So it sounds better, but the problem is it's extremely sclerosing to peripheral veins. If it extravasates, it causes horrific skin necrosis.
So it's a safety issue.
It's purely a safety issue. Unless you have a secure central line or the patient is actively coding, you should stick to the much safer calcium gluconate for peripheral administration.
Okay, let's move into the OR, the surgery itself, parathyroidectomy. What's on our preoperative checklist?
Airway is number 1, 2, and 3. Many of these patients have a concurrent thyroid disease, a large goiter, tracheal deviation, maybe they've had previous neck surgery with scarring. You need a rigorous airway assessment and a plan A, B, and C.
Why do we need to check the vocal cords preoperatively?
This is both medical, legal, and clinical. You must document pre-existing vocal cord palsy via an indirect laryngoscopy.
So you have a baseline.
You have a baseline. If the patient wakes up hoarse, you need to know if it was you, the surgeon, or the underlying disease process that caused it. And critically, if they already have one paralyzed cord, you have to be terrified of injuring the other one.
Because that would mean
a bilateral cord palsy, a lost airway, a tracheostomy.
What labs are we checking just before surgery?
Calcium and phosphate, obviously, creatinine to assess renal function, and alkaline phosphatase.
Why ALK-Phos specifically?
A high alkaline phosphatase indicates high bone turnover. It's a strong predictor of postoperative hungry bone syndrome.
So if ALK-Phos is high, you know the bones are starving for calcium. We'll suck it all up once the adenoma is gone.
Precisely. You can anticipate and prepare for severe post-op hypocalcemia.
Let's talk about the anesthetic technique. General or regional?
General anesthesia is the standard of care. It provides a secure airway and a completely motionless surgical field. However, for a minimally invasive parathyroidectomy, where they know exactly where a single adenoma is located, regional is an option.
A cervical plexus block.
Yes, either a superficial or a deep cervical plexus block. The huge advantage is that the patient is awake and can phonate. You can monitor their voice in real time. But practically speaking, most surgeons and patients prefer the comfort and control of GA.
And positioning.
The rose position. Head up to reduce venous engorgement and neck extended to expose the surgical field. But you have to be careful.
Fragile bones.
Fragile bones. These patients have osteoporosis. Don't just crank the neck back aggressively, or you can cause cervical spine fractures or an atlanto-occipital joint injury.
Monitoring. Anything special beyond the standard ASA monitors?
The big one is nerve integrity monitoring, or NIM. We touched on this. It's a special endotracheal tube with electrodes embedded in it that sit right against the vocal cords.
And this has a major implication for our drug choices.
A huge implication. If the surgeon is using NIM to help identify the recurrent laryngeal nerve, you cannot paralyze the patient after induction.
The nerve has to be able to fire.
It has to be able to fire when stimulated. So a typical plan would be to use succinylcholine for intubation because it wears on quickly, and then run the rest of the case on a deep inhalational agent or a propofol remifentanil infusion. Deep anesthesia, but no paralysis.
Okay, let's talk about what happens after the drapes come down. Post-operative complications. What are the big 3 that can happen in the recovery room?
1. Hematoma. 2. Nerve injury. 3. Hypocalcemia.
Hematoma is the immediate killer.
It is. The neck is a tight, closed space. If an arterial bleeder lets loose under the skin, the pressure rises instantly. It compresses the trachea directly, but just as importantly, it collapses the venous drainage, which leads to massive laryngeal edema. The airway just swells shut.
What's the management?
This is a do not pass go, do not collect $200 situation. If the patient has stridor and a tense, firm neck, you do not call the surgeon and wait. You do not send them for a CT scan.
What do you do?
You take a stitch cutter or a scalpel, and you open the surgical incision right there at the bedside, evacuate the clot, decompress the airway. Then you can worry about going back to the OR.
Nerve injury.
Unilateral injury to the RLN causes a weak, breathy, hoarse voice. A bilateral injury is a catastrophe. The vocal cords lose their ability to abduct, and they flop together in the midline during inspiration.
Complete airway obstruction.
Complete. That patient needs immediate intubation or a surgical airway.
And finally, hypocalcemia and this hungry bone syndrome.
Right. Simple hypocalcemia from gland removal or ischemia usually peaks at 24 to 48 hours post-op. But hungry bone syndrome is a different beast. It's profound, severe hypocalcemia.
Why is this so severe?
Imagine the bones have been stripped of calcium for years by the high PTH. The second the adenoma is removed, PTH levels plummet. The bones collectively say, it's dinner time, and they aggressively suck calcium, phosphate, and magnesium out of the bloodstream.
So the serum levels just crash.
They crash hard, and they're often very resistant to normal calcium supplementation. These patients frequently need continuous IV calcium infusions and high-dose active vitamin D for days or even weeks.
Quick question on calcium in the ICU. When we measure a calcium level, what are we actually looking at?
That's a great point. The standard lab report gives you the total calcium, but only the ionized calcium is physiologically active. The rest is bound to albumin.
So if a patient has low albumin,
If your patient is hypoalbuminemic, which is incredibly common in critically ill patients, their total calcium will look falsely low. Their ionized active calcium might actually be normal or even high.
is there a correction formula we can use?
There is. Roughly, for every 1 gram per deciliter drop in albumin below 4, you add 0.8 to the total calcium level. But in an exam, you should always say, I would check the ionized calcium level directly to confirm. That's the gold standard answer.
We're getting to the home stretch now. Let's do a quick comparison table fire drill like a Viva. I'll give you a parameter. You give me the hyper versus hypo distinction. Ready?
Let's do it.
QT interval.
Hyper is short QT. Hypo is long QT.
Muscle tone.
Hyper is weakness and hypotonia. Hypo is tetany and spasm.
GI symptoms.
Hyper is constipation, nausea, pancreatitis. Hypo is cramping.
Don't forget metabolite.
Phosphate. In primary hyperparathyroidism, phosphate is LOW. In hypoparathyroidism, phosphate is HIGH.
Okay. Diagrams. If the examiner asks you to draw something on the whiteboard, what are you drawing?
You draw the anatomical relationship of the recurrent laryngeal nerve to the parathyroid glands. Superior is dorsal, inferior is ventral. It proves you understand the surgical anatomy in a second.
Anything else?
The PTH feedback loop. A simple diagram showing high calcium inhibiting the parathyroid gland. It's simple, but it's core physiology.
Let's talk about common Viva traps. What do students usually miss?
They always forget magnesium. They forget that hypercalcemia is a state of profound dehydration, and the biggest one. They fail to state that management of a neck hematoma starts at the bedside with immediate decompression, not in the OR. If you say, I'll call for help and prepare for a difficult intubation, you fail that station.
Right. Action is needed. Let's wrap this all up with a summary. Give us the absolute core high-yield takeaways.
Okay. Number 1, 4 glands. The inferior one comes from the third pouch. Remember the paradox.
Got it.
2, PTH raises calcium by looting the bone, hoarding from the kidney, and recruiting the gut via vitamin D.
Right.
3, hyperparathyroidism equals bones, stones, groans, moans, and critically dehydration and polyuria.
Okay.
4, hypercalcemic crisis management is rehydration first, Lasix second. 5, hypoparathyroidism means twitching, tetany, and the risk of laryngospasm.
And the big one for post-op?
Post-op airway management means you watch for a hematoma like a hawk, and you are prepared to open the incision at the bedside.
Excellent. And to leave our listeners with, what's a final provocative thought? Something to mull over.
The intraoperative PTH assay. In modern surgery, we don't just guess if we removed the right adenoma anymore. We measure it in real time.
How does that work?
PTH has a very short half-life, only about 3 to 5 minutes. So we draw a blood sample 10 minutes after the suspected adenoma is removed. If the PTH level drops by 50% or more from the pre-incision muck line, it's a biochemical cure. We know the surgery was successful before we even put the final dressing on. It's physiology happening right in front of you.
That is a fascinating application of physiology to improve surgical outcomes. All right, that is your deep dive on the parathyroid glands. Visualize those little yellow bodies watch the calcium, and always respect the airway.
Good luck on the exam. You are ready.
See you next time.